Good afternoon, Jerry. How are you doing today?
Good. How are you?
Good, good. It's always a pleasure to talk to you. And I want to take your expertise today as we come into the election season. With election season is heating up. Joe Biden is, I believe, going to announce his running mate in the next few days. And the moment he announces the running mate, everything heats up. Now we are almost in the election season, 95 days away. And healthcare happens to be a critical component of the country always, and it is going to be a very hot issue. I would like to take your expertise and seek your opinion on topics related to healthcare because you're an expert in this area. And I want to start with one question. If you take healthcare as an example, healthcare has two components to it. How do you manage individual health, which is individual responsibility? And for whatever reason, if the individual either is not able to take care of himself or herself, and then they get into a medical situation where they need to go and see a doctor, then you have a healthcare insurance so comes into place, which is nothing but a medical insurance. So tell me, for a layman, how does various insurance programs work in this country? Number one, if I am a student coming from an India or any other country, how does the insurance work? And I want you to elaborate and help our viewers to understand, people who are not in this country as well as people who live in this country, to categorize various types of healthcare topics. To start with, I want you to give your perspective on what is a healthcare, what is a medical care, how does the insurance kick in for various groups of people in the country. With that, I want to give you the chance to explain your perspective on health and medical care, health and medical insurance, and go from there.
Okay. Taking your question about a foreign student coming to the country and, what do they have to do? Well, they have to, of course, get a policy. And that can be written, as you had indicated, maybe by the groups provided by the college or something, but you do have to have coverage. And to activate the coverage, you have to have a physician. You're going to need a primary care physician because nothing starts and is activated until you have a primary care physician. And that primary care physician then has he's a gatekeeper, he or she. They have the responsibility for determining what your diagnosis is. All this is going to start with a diagnosis. It's an input, a description of what they think after reviewing the symptoms with the patient, what the diagnosis could be, because they're not going to be able to do that without testing and some scientific evaluation or assessment to what the needs are, because you can't start the whole health insurance machinery without having a primary care physician. And then at that point, once the diagnostics are done and the physician determines whether he's got the capability in an office to do that, or if it needs to have x-rays and blood tests, they don't do those in the doctor's office anymore. They used to, but not anymore. Then it starts to involve a clinic, an outpatient clinic or emergency clinic or the hospital. And those orders can be done electronically. And that's where the integration of the entire healthcare system needs to go. They're not there yet.
Okay.
So
this is for the student.
In order.
Okay, in that order. So this is for the student who's coming from international, or a different country. How does it work for people or students who are American citizens? How does that work?
Well, it works the same way. They have to have a policy. They have to have a physician. They have to have an order to get anything done. and the
Okay.
physician is the primary gatekeeper on that.
Okay.
And it's just, then it goes through the entire healthcare continuum, depending upon the severity of the illness, the age of the patient, their coverage, and whether it's going to involve third-party payors to pay the bill.
Okay. And in case, okay, now we discussed about students. Now the student finishes his master's or whatever undergrad he's doing, he now gets into a job. How does that change his insurance, thing, insurance
Well,
policy?
uh, the company then becomes typically the provider of a group insurance policy, which they sign on for. And it used to be in the old days with Blue Cross that the employer would pay it all. Well, as costs escalated and the employees were getting benefits to the point that the companies couldn't afford health care without a sharing. So now the employees share in a commercial insurance environment, which is what we're talking about. They have to share in the cost of that. So, if it costs $1,000 a month, and that's probably typical, the employee is expected to so-called pony up for $200 or $300. And if it's a family policy, then everything doubles. And once they have the policy again, that the whole system starts up with a physician. They have to have a physician, and that physician, if need be, then recommends specialists, because we're still it's the general practitioner and the heart doctor and the stomach doctor and all the doctors get involved. The physician is the one that creates the orders to activate that.
Okay.
The physician is also the one that admits them to the hospital or the emergency room, or gets orders from a clinic to be able to extend that into hospital care.
Okay. And now let's talk about the continuum. Now the student who has come into this country and the student who was born here, he has gone to the school, from there he got a job, now he's retired. How does that work in that case?
Well, retirement means that there are companies that have benefit plans that follow a retiree and pay all of his health insurance, his or hers, or a portion of it. It just depends upon probably the stature of the employee in the company, because the higher up, the better the benefits. But typically, the insurance stops, and the retiree then has to either get his own individual policy or a family policy, or if there's over 65, Medicare kicks in, but then you have to have a supplement to cover the co-insurance and deductibles, because all these insurance policies have cost sharing with the patient in the form of co-insurance and deductibles.
Okay, so when does the Medicare kick in at this point? Is it the Medicare is for the retiree insurance, or when does the Medicare? I hear the term Medicare come in.
Well, Medicare has got two basic trust funds. One's for the hospitalization and nursing homes. It's called Part A. And then they have the Part B portion, which is for the physician and outpatient services. And it's bundled into the Medicare package of services. To qualify for Part A, you have to have had a hospitalization. Mm-hmm. Under Part B, that's for testing to determine if they should hospitalize. When they get to the hospital, again, we have a split between the hospital and physicians. Some hospitals employ physicians, so it's rolled into the hospital's Medicare billing. And there's, again, an adjustment made or a formula to separate the physician from the hospital. Regardless, it comes out of the different trust funds. And so with the student that's admitted to a hospital, or no, we're talking a retiree retiree is admitted to the hospital, they then give the hospital their Medicare card and then their Medicare supplement, which is a private insurance company paying the copay and the deductible. So then they have to have, just to trigger all this, they have to have, of course, the physician, the gatekeeper, primary physician, family physician order to admit you. You can't get admitted without that order.
I see. So then you have within Medicare, you have Part A for hospitalization, Part B is for physician visits, and supplemental insurance for copays. So that is how the concept works.
Well, Part A also applies to a nursing home
I
if
see.
you've had a hospitalization.
I see.
And it's split there into Part A and Part B. The physician is separate again from the inpatient stay, and the inpatient stay is limited to a certain amount of coverage. All insurance is limited by a certain specified um, uh, extent, length of stay. Like in Medicare, it's 100 days. Length of stay is the maximum, but 20 days is before the copay sets in. But to run 100 days, you have to have the justification of the physician and the therapist determining that you need to extend that coverage. And typically, the people are not getting their 100 days. It's the decision is made by the therapist in a nursing home setting on the and the nurse as to whether they can extend that stay to 100 days. They're really needing 100 days and they're not getting it typically because they just, over the years, government started running out of money on the Medicare and they started denying claims.
I see.
So in a nursing home, they'll deny a claim that goes much beyond 20 days. But in most cases, the elderly have 4 or 5 diagnoses going on and they need 100 days to be restored. And in our experience, when we were running the nursing homes, of course, we wanted to get them as much of the 100-day benefit as we could because it gave them longer to recover. And our goal was to return them home. Nursing homes, typically, their goal is to keep them and, if they have private money, to get them off Medicare so they don't get a denial. And then they spend all their money and then they have to go on Medicaid.
Right.
And Medicaid is kind of a welfare program. Because
so I was coming to that. Before hold your thought on the Medicaid.
Okay.
I want to ask you another. I wanted to clarification. So in this Medicare Part A, Part B, and supplemental, does it cover for preventive medications like vaccines and regular diagnostic visits and those kind of things are covered? Where do they cover in Medicare?
Yes, that's under Part B.
Under Part B.
The Medicare pays for flu shots, shingle shots, tetanus shots, pneumonia shots.
I see.
Because of the preventive nature they feel of those vaccines.
Mm.
That's the only really part of the Medicare program that's paying much for prevention.
I see.
And Medicaid typically doesn't pay for any preventive
services, preventive medications.
Yes. Right.
Okay, so when Medicare, when a patient runs out of money in his Medicare account, is when Medicaid kicks in, and which means Medicaid.
If they've spent down,
yeah.
They have to spend down their personal assets to $2,000, which is a burial fee. So they don't have to spend down their spouses, but their own, they have to spend it down to qualify. And Medicaid takes their time to determine through background checks and investigation that you aren't hiding assets to be able to get the Medicaid program to pay for physicians and nursing homes and tests and so on.
So which means somebody, if an elder couple have some savings, they will not come under qualified for Medicaid unless those savings are exhausted and they don't have any more savings to support for their medical need.
Yeah, only if the savings accounts are joint.
Okay.
There's always advantages to split the assets if one is in a nursing home and the other one isn't,
Mm,
because the other one needs to get their Social Security check, whereas the Social Security check for the patient goes to the nursing home.
I see.
So it's better if you split ownership of your assets as you age, if it's going to be a situation where you have to spend down.
Okay. And
In many cases, they will force you to sell well, they will force you to sell property before you qualify.
mm,
That includes farmland. Um, again, things that are held in joint tenancy, uh, that gets to be a little complicated.
mm,
But in the past, it was simpler because you could give away your assets before you had to go on Medicaid, and now if you give anything away within a 5-year period, then you won't qualify for Medicaid because you were attempting to hide assets that the state Medicaid program uh, wouldn't have to pay
I see.
for.
Okay. Now, let me also ask you, what is then this Medicaid looks like this based on what you just said. Medicaid is targeted for those people who cannot afford medical insurance or who do not have medical insurance.
Yes, and we're basically creating indigency by forcing them to spend down all their assets. The family does not have to contribute any of that.
Hmm.
They're not required by the regulation, the law or regulations that they have to take over the responsibility to pay the bill. And so it really creates a dependency on the state welfare program. It's called public health program to pay what they determine would be an adequate amount of money to not restore, but to maintain and house the patient. So the medical services don't cease. I mean, you will have to have certain medications. Most of it is medications and labor for the nurses and nurses' aides, but you have to have supplies. And so there are formulas that determine how much Medicaid is going to pay as you go. And these formulas have all been attached to cost reports, and the cost reports are 2 or 3 years old. So the payment typically for a Medicaid patient in a skilled nursing facility is not adequate to give them the standard of living that they expect and have used to. And it's more of a maintenance situation, and it's done more at the end of life. And Medicare can come back in if you're rehospitalized.
Right.
The rule under Medicare is if you're rehospitalized and have another 3-day stay within 60 days, you can then get another 100 days.
Hmm.
And
So
then,
it is per episode.
pardon me?
It's per episode, per admission.
Yes, right.
Okay. Okay.
And that then extends they call it the skilled nursing portion of Medicare. And then you'll get some more therapy and you get some more physician involvement, and then they will decertify you for Medicare and put you back on Medicaid.
Mm.
And then the bill goes to Medicaid, not to Medicare.
Do you see any, based on your experience, do you see a huge difference between the services provided under Medicare and Medicaid? Is there any difference, or is it just that who pays for it?
No, there has to be a difference because the patient post-hospital has maybe, respiratory, dietary problems, and they're getting a higher level of pharmacy in the forms of prescriptions, and also uh, uh, prescriptions and feeding tubes and injections. So there's a lot higher costs when they're on Medicare. Most of those are for short-term usage. Usually, that when they start decertifying them from Medicare, they have gotten to a point where they still have prescription drugs and they still have injections, but now are paid by Medicare Part D. So now we have a Medicare Part D that is billed for the Medicare patients that have opted for Medicare Part D. And so the bill will then be sent. You're on Medicaid, you have Medicare Part D. They're going to send the bill to Medicare for medications. And then there's a Part C Medicare, which, not to confuse everything, is saying that an insurance company will manage your Medicare benefits. And they will also cover the copay and the deductibles. And
Right.
they're marketing this as a package. And then they start offering all kinds of things they call free, which aren't free, but eyeglasses and hearing aids,
Hearing aids.
transportation, and all that's rolled into one package. And those are sold by insurance companies.
I see.
And then insurance companies parse out the billing to Part D or Part A or Part B. And then they have a contract with the government on a capitation basis where they're making their money on making sure that the patients are not kept on any services too long. So
Wow.
then we get into the denial process.
Right.
And the
It
whole
sounds
thing.
very complicated based on what you're describing. So that leads me to another question. Pardon me for asking me a few dumb questions. This may sound dumb to you because you're an expert in this field.
Oh,
What is
they're not dumb questions. They're
uh,
actually a real world problem with
right,
Medicare and Medicaid for all.
right.
It just isn't going to happen.
I know. In fact,
It can't happen.
I'm going to come to that as well. That's a separate topic by itself because okay. So what is this chip insurance then?
That's for children.
Oh, it's for only for children.
Yes,
Mhm.
yes.
So which means those children who don't have any insurance coming from their parents, or okay, is that because they are illegal immigrants or they don't have a job? What does chip mean?
Well, if there's no other source of payment for children, then the program picks up the bill. It's kind of like Medicare for children, or Medicaid, maybe more appropriately, where under Medicaid they will cover the children, but they have to go through the process of being screened by a doctor. And so those are billed specifically for the children. It's not the parent that is the basis of the coverage, it's the children. Those typically in the inner cities are at clinics, Medicaid clinics.
I see. So for poor neighborhoods where they don't have any way of paying for the healthcare for children,
Yes.
it comes
Yes.
under the chip insurance. Okay,
Yes.
now for all of these categories, okay, so where does people who are illegal immigrants who don't pay any taxes or who are not in any official registry, if they fall sick, how do they get taken care of?
Well,
Which part?
it depends on the state. The states administer the Medicaid program. They share in the cost of it with the federal government, depending upon their population. But that's where it gets sticky. Is the Medicaid program going to pick up any of the costs of the homeless and the alien
Immigrants.
immigrants?
Right.
And California says they will, to a certain extent. The large states, I don't think New York does. I think it goes from state to state on whether the Medicaid program is going to pick up any of that. That almost has to be a part of are they a sanctuary city? And if they are, it could be that the county or the city will have to pick up those costs, or the hospital eats it as charitable care. And they do. Most hospitals that have used federal money to build their buildings have to provide charitable care. And so that's probably where that enters in. It's like Cook County Hospital, the emergency room was full all day long with those type of people that need health services and don't have any source of payment.
I see. So Chicago happens to be a sanctuary city, if you will. So which means they are supportive of taking care of illegal aliens who don't have medical insurance,
Yes.
and then they they get into an emergency room, and then they take somebody will pay for it. So that is what. What happens? Let's say someone who is okay. The Medicare. The question I had was Medicare is for
By the
retirees.
way, Karthik, by the way, that's why Chicago is bankrupt,
Oh
because
yeah.
they've taken on these responsibilities and they can't even pay the government pensions that
Right.
are escalating. But didn't want to let that go by.
Right, right. Yeah, I agree. I completely agree because sanctuary cities are nice sounding words, but the fiscal impact of these sanctuary cities on the taxes, on the way they manage it, that's a different topic altogether. We'll come to that at later. So
Yeah.
I had one question. So the Medicare is for retirees. So which means typically it starts when someone is above or almost 65, right? That kicks in at
No, it has coverage for um, dependent children. It has some coverages for disability. Medicare will pay for, if you qualify for, well, disability is actually a Social Security payment, SSI, but Medicare does have benefits for a retired dependent children.
hmm
They can qualify for some healthcare services under the Medicare Part A program,
I see.
not Part B.
hmm And so now let's say I'm going through my life's continuum. You have a child who gets covered by his parents' insurance. If he's a citizen, he goes into school. He or she goes into school, graduate, they get into a job. When they retire, they get Medicare. What if they get laid off in between? Who takes care of their insurance? They also have family at that time. They have kids. Who takes care of that insurance part?
Well, there's what do they call that?
Is that Cobra?
COBRA. Yeah.
Yes.
Yeah, they have a certain period of time to get their own insurance.
Right.
It may be up to a year,
Right.
depending on the employer or the fact the employer has the COBRA coverage.
Mm.
And then they have to get their own policy.
Except
And
that it looks like they will have to pay a little more than when they were in employment till they find another employment.
yeah, probably have to pay the whole premium for a while. And that's
Right.
where Obamacare was supposedly going to come in
Mm.
and start covering everyone. Well, we still have 27 million uninsured Americans,
Mm.
down from 44 million when Obamacare got passed. But it's increased 500,000 people came off of Obamacare in the last year
Last
because
year.
of some of the insurance exchanges, if they can't generate enough physicians that will cover their patients because of the high deductibles, then they're coming off of Obama and are uninsured again.
I see. I see. So they are.
Obama didn't fix the uninsured.
Oh, so it didn't. So what happened? What was the intent of that program was to ensure that everybody gets coverage, and looks like they're flipping off and on of the program because of the service
Yes.
levels of the program itself
Plus cost.
plus costs.
Yeah, the cost sharing by the patient is so high they can't find a physician to handle their primary care requirements because the deductibles are so high, and the physician won't take them until they've covered the deductible. It could be $4,000.
Mm-hmm.
So they're not getting a
The
primary care physician because they won't take them. And so that was the biggest problem. And then the next biggest problem is when you are admitted to a hospital, then the difficulty is to make sure that they have the deductible paid for,
right.
or that it's going to be paid for, and then they can turn these over to collection agencies or can tap their bank accounts to collect healthcare bills anymore. So the hospital is being a bad guy because they haven't covered their deductible. So they
Right.
tend to go to the hospital. They tend not to go to the physician. They have Obamacare, but they haven't been able to cover the deductible.
Mm. Right.
And then when
So
they
I
get
think
to the hospital, they got a co-insurance to pay, that they supposedly have to pay.
so, which means that if, because the reason why I'm asking is one of the, so if let's say I compare and contrast with insurance from a different other countries, for let's say countries like India, they typically don't have any insurance for anyone. So if you are working for a company, you're working as an, you are not working, you just have to go to a private hospital or government hospital, government-run hospital. Government-run hospitals are not as good as private ones. However, private ones are known for not being very honest with their billing, and they have all kinds of problems. So, medical insurance is something which they have introduced some programs at federal and state level over a period of time, but all of them are really heavily subsidized by the state or central governments, which are not sustainable in long term. So healthcare looks like a big challenge for every nation, including US, and US happens to be a biggest, spender of the healthcare. Right now, I want to pivot to a different type of a topic in this. One is there is medical
Could I,
care.
could I comment on that?
Yeah, absolutely. Go ahead.
Um, yeah, the United States is number one in cost per capita for healthcare insurance. They're number 38 in terms of quality, and that's measured upon infant deaths and some other criteria.
Hmm.
And you were saying, most, if not all countries have this problem of funding, except for Singapore.
Right.
Now, Singapore is only 5 million people, and we're
30
330
million.
million.
Right.
Yeah. But they are number one in quality and the lowest cost per capita. And they have, I would call an enterprise model of healthcare, which I'm a proponent of, where they have a collaboration between government and the providers and the patients to share in the costs. So the costs are not all being sent to the government, who has tremendous overhead and eats up half of the money through the bureaucracy. Is that at those different levels, they have different responsibilities for funding. So they're funding, the patient is funding this as they go in a savings account.
Mm-hmm.
And then the providers are willing to take payments from those savings accounts, and the government is covering the difference. So now we have a partnership of responsibility for payment, but also responsibility for providing outcomes, not
Right.
just treatment. Because now it's going to prove, if everybody stays healthier, which this is the point, is if the person's savings account is being tapped, they're going to want to know what they're paying for and what they're getting. So now the providers have to be accountable for that. And we got a healthier patient, and we got providers not providing cures or pursuing outcomes or getting them better to prove that they are quality. And then during that, the patient has a right to say, what am I paying for and how much does it cost? And they're required to communicate that. It's transparent, true transparency. And the government is entering in and paying the differences at different levels of care. So there is that program that is actively being touted as the best approach, economically and wise and preventive wise, because in that are preventive services that never get paid for in America. They call taking aspirin a preventative service, or mammograms or whatever. But no, that I've taken a look at that, and it's in my book, The America in the Red Zone, about how they do that.
That's a fantastic comment. And it looks like, I think based on what you just said, US also has collaboration in terms of, except that there are missing pieces if we compare the two models. We also have providers, government, and the patients have worked together here, except that we don't have savings accounts here. Savings accounts are only enforced at certain level. However, there is no accountability enforced, number one. And remember, Singapore is a fine city. They are very, very good in fining. In case if they find providers or hospitals or anybody doing any fraud, they get fined, they'll be out of business.
Good.
whereas whereas in US, I think at some point that is loose and it's very hard to control fraud or high
And
overcharging.
in the United States, we have monopoly because the government contracts with the insurance companies. And they also contract with the providers.
Mm,
They have the ultimate control, which is a monopsony. It's the opposite of a monopoly.
mm,
The buyer of the services has a monopsony, control over everything. And in that, and there's no competition in the providers because they now don't have to compete with anything except the government and what they're willing to pay. They're paying on averages. They're not paying for episodic care, or they're not paying for approving an outcome.
right.
They don't. The providers don't even have to prove their costs for a stroke. They get a certain amount of money for the 4.5 days, depending on the cost report they paid, and that's an algorithm or an average amount per day.
Mm,
So this whole thing is built around what I call a monopsony board, where the government is in control of all the flow of the money.
right.
And that's what we thought we were going to have in a democracy.
Right.
But that's what we've evolved into.
Hmm.
And I know you didn't want to get into that maybe today, but
Right.
I
Right.
think that's important.
I agree. That's an important, and then especially important. I know that's a topic for a different day. But what I definitely would like to, I think, in summary, say is Singapore, the way their model is effective is because they are enforcing personal responsibility of the patients, provider
Yes.
responsibility, and
Yes.
government accountability, so that
Yes.
they are adjudicating the cases properly with responsibility and accountability. I think that is where, and they're contributing to it, to the whole situation based on the model they came up with. I think, which is very effective, especially in the COVID-19 situation. Singapore happens to be one of the lowest in
Yes.
lowest number of cases, as well as lowest number of mortality. Given their population is not very heavy, however, it still is a success based on what they're doing. But I would like you to pivot to a different topic. One is, um, healthcare has two components. One is individual responsibility of maintaining their own health, taking care so that they don't get into this chronic diseases like a diabetes or obesity, and things like that, so that their dependence on medical insurance becomes heavier. Number one. Number two, because Medicare is a group insurance, if the group is, you're as you're as good as how healthy the group is. If the majority of the people in the group are sick, the whole program goes sick. And if the majority of the people in the group are healthier, it'll be much more efficient. So I think we should be talking about healthcare and individual responsibility in our next video. I think I got a very good understanding on how the healthcare works in this country, healthcare insurance, if you will, works in this country. And you brought some interesting models like Singapore versus US. I think next topic, I would like to delve a little more deep, because this is such a vast subject, especially US happens to be the top in the technology, biotechnology, medical services, medical facilities. However, the startling numbers you gave, it is the highest per capita per spender in the world, but 38 in outcomes, which is
38.
38
38.
in, yeah, in 38 in outcomes, which means there's a huge dichotomy, if you will, between the amount of money we spend and the amount of returns we are getting on the patients.
And it's really a definite definition of quality, not outcomes,
Right.
because we're still not dealing with healthcare as a continuum of care from the physician to the hospital to the nursing homes to the therapist to the to the home care and assisted living, and then making the cycle again in an episodic way. Until we're doing that with artificial intelligent models, which I call the enterprise model, not the medical model. And I know we're going to get into that, but we're not pursuing prevention. We're not pursuing preserving the health, which those are personal responsibilities that we relegated to the government just on the basis of will they pay for it or not. And so right now, the cost overall is $4.5 trillion a year for healthcare services in America. That's I think it's now $14,000 a person.
Mm.
And the young pay most of that, and when it comes to group insurance.
Right.
And even for Medicare, they're paying into the Medicare fund as well. And this whole thing about this payroll tax holiday, that takes money out of Social Security and Medicare is where it's coming out of. Because that's what's funding. Social Security and Medicare is funded out of that payroll tax deduction,
right,
where the employer shares it with the employee. So I would say watch out for that one.
I know. Today, Trump has signed the executive order. I will have to see if it is covered in that or not. But anyway, that's a topic for a different day. Thank you for your time, Jerry.
I'm sorry, I keep jumping ahead of you.
Oh, that's fine. That's fine. That this is there are so many things going on every day that, there's so much of news, but I want to take one topic at a time, and we have unlimited topics. I'm pretty sure. As always, it's a pleasure to talk to you, and very, very enlightening, educating for viewers when they talk to people like you. I really enjoyed your talk, and then I look forward to talking to you next week.
Yeah, these are documented in my books. I know you said next time.
I think you should show your book, title of the book on the video for our viewers.
Well, I have 9 healthcare books, so
pick the one. Pick your choice. Pick one of your book.
I don't know if that's showing or not.
You should move it to the left. Yeah, I think now it is coming. The boomers are coming. I see that.
Yes.
I think.
Yeah.
Okay. Thank you very much. And
it's about the baby boomers, but it covers a lot of what we've been talking about.
Okay. Thank you for your time. I appreciate it. And have a good weekend.
You too.
Thank you.
Take care.
Take care.